Yeah. Good afternoon, everybody. So today we shall deal with breech presentation. So, which is one of the important presentation in obstetrics, which we have to tackle. And breech means the fetus is said to occur in breech presentation when fetus is longitudinal and in buttocks of the fetus enter the pelvis first. To show you, this is the pelvis. This is the breech presentation. This is the head of the fetus, this is the breech, and this is the back of the fetus. The most common presentation in breech presentation, the left sacroanterior position. The sacrum lies in the left, facing the left side of the pelvis. This is called, the denominator is sacrum in breech presentation. As in cephalic presentation, occiput is the denominator. The denominator means a bony point in the presenting part is called the denominator. In cephalic presentation, occiput is the denominator. In breech presentation, the sacrum is the denominator. Depending on the position of the sacrum, left sacroanterior, right sacroanterior, left sacroposterior, and right sacroposterior. These are the four positions that the fetus can occupy in breech presentation. So as I said, the breech presentation when the fetus is in the longitudinal line and the buttocks of the fetus enter the pelvis first is called breech presentation. So this is how the uterus, the fundus, and the head at the fundus and the breech in the pelvis occupying the lower uterine segment. The presentation, breech presentation depends on the period of gestation. Up 32 weeks, then it may be 16%, but later on, as the baby moves inside the amniotic fluid, it may turn to cephalic presentation. So 16% at 32 weeks, and 7% at 38 weeks, and 5% at 40 weeks. So incidence of breech presentation at term is only 5%. Varieties of breech presentation. It may be complete breech or incomplete breech. Fetus is in attitude of universal flexion. That means there is flexion at the hip, flexion at the knee joint, and head is flexed, and both the hands are flexed at the elbow, and this is called complete breech. Okay, sacrum occupying the left sacroanterior position. The left sacroanterior position is the commonest position in the breech presentation. So this is what complete breech, and second one is incomplete breech, or the third one is frank breech. These are two types of incomplete breeches. The complete breeches is a universal flexion with the breech presenting at the lower uterine segment or occupying the pelvis. Incomplete breech, and then the frank breech means both the legs are extended at the knee joint and lie straight. This is called the frank breech or extended breech. This is how, this is complete breech and this is frank breech. Complete breech means both the legs are extended at the hip joints and flexed at the hip joints and extended at the knee joints. This is the second one is the frank breech with the complete flexion and footling presentation, where the foot will be presented and enter into the pelvis. The cause of breech presentation are: one is prematurity, second is multiparity and multiple pregnancy, then fetal anomalies like hydrocephalus, where the presentation is mostly breech. Because of the used head in hydrocephalus, head can't get engaged in the pelvis. And obliquity of the uterus and uterine fibers, any tumors related to uterus will give mostly the breech presentation. Then the other causes are placenta previa, where the placenta lies in the lower uterine segment, and the associated ovarian tumors with pregnancy, and the contracted pelvis and corneal implantation of placenta are the other causes of breech presentation. The positions, as I said, left sacro-anterior is the commonest, then right sacro-anterior, right sacro-posterior, then left sacro-posterior in order of frequency. So amongst these, the commonest position is left sacro-anterior, as the sacrum being the denominator in breech presentation. To diagnose breech presentation, first on palpation in fundal grip, head suggested by hard, globular, palpable mass. When we do the fundal grip, you find a hard, palpable head at the fundus. As breech is in the pelvis, the head is at the fundus. So we'll be able to feel the hard, global, palatable mass in the fundus. In the lateral grip, you find fetal back to one side and the irregular limbs on the other side. And pelvic grip, breech suggested with soft, broad, irregular mass when you do the pelvic grip. So by this, on palpation, we can diagnose breech presentation. On auscultation, usually the fetal heart is located at the higher level above the umbilicus, whereas in cephalic presentation, the fetal heart lies below the umbilicus on left side or on the right side, depending on the position of the head. Then by vaginal examination, palpation of the distal tuberosity on either side of the anus being in the middle and the sacrum behind. So when we do the vaginal examination, we'll feel the ischial tuberosity of fetus with anus in the middle and the sacrum behind. In complete breech, feet can be felt by the side of the buttocks. Feet will be felt in complete breech. When we do the vaginal examination, the feet will be felt and we'll be able to touch the feet of the fetus. And the buttocks felt, uh, feet can be felt by the side of the buttocks, while the extended breech, feet is not felt. Because in extended breech, both the legs, this is in extended breech, that you will be not feel the feet, because the feet will be close to the chest wall. So you will not be able to feel the feet. So by this, we can make out whether it is a complete breech or an incomplete breech. Coming to the delivery, vaginal delivery, that modes of vaginal delivery are spontaneous breech delivery, assisted breech delivery, and routine breech extraction. Mechanism of labor. The buttocks engaging diameter is bitrochanteric or called bitrochanteric or bisciliac diameter, that is 10 centimeters. When the breech gets engaged, it gets engaged by by trochanteric diameter, and in left oblique diameter. Engaging diameter is bitrochanteric, and descent of the buttocks occurs. Then the internal rotation occurs, and internal rotation of anterior buttock, further descent in, we call it as in cephalic presentation, the descent with flexion. Here in breech, we call it as descent with compaction. It takes place further descent with lateral flexion of the trunk. It is called descent with compaction. In cephalic, we call it as descent with flexion. Delivery of the trunk and lower limbs take place, then restitution takes place, and delivery of the fetus occurs. This is a mechanism of labor in breech presentation. Shoulder gets engaged in the opposite diameter as that of the breech, that is by a bisectromial diameter, that is 12 centimeters. Engages, descent occurs with internal rotation, delivery of the posterior shoulder, and restitution and external rotation occurs. This is how the shoulder gets delivered. Then the head gets engaged and descent with increasing flexion and internal rotation of the occiput, and further descent, and head is borne by flexion. This is how in breech, delivery of the breech, delivery of the shoulders, and delivery of the head. What do you mean by assisted breech delivery? Assisted breech delivery encourages the patient to bear down and wait for further delivery of the trunk up to the umbilicus. When we are conducting delivery in a patient with breech presentation, you must bring the patient to the edge of the table. Encourage the patient to bear down and wait for delivery of the trunk up to the umbilicus. So, to umbilicus, you, at the edge of the table, labor table, you allow the trunk to hang on its own weight so that the head gets engaged. Umbilical cord pulled down and mobilized to the side to prevent compression. With the umbilical cord, you have to get the cord to one side of the fetus so that it doesn't get compressed. So if the cord gets compressed, the fetus will become dyspneic and the oxygen saturation in the fetus will come down. So you must prevent cord compression by delivering the fetus by breech. Rotate the trunk to bring back anteriorly. Wrap the baby with sterile towel to prevent aspiration. When the whole trunk comes out and the head is inside the uterus, due to the external stimuli, the fetus will take respiration. Then the liquor is likely to be aspirated when the head is being inside the uterine cavity. So you must, to prevent external stimuli, you must cover the baby entirely with sterile towel that will prevent external stimuli, and the aspiration of liquor can be prevented. The delivery forms, then the delivery of after-coming head by Burns-Marshall technique. The delivery of the hands, if the hands are extended or in nuchal position, we must resort to Smeliewicz's maneuver. And where we'll do shoulder flexion, jaw flexion and shoulder traction. Burns-Marshall method, modify to deliver the head by Burns-Marshall technique means you must bring both the legs of the baby towards the maternal abdomen in an arc-shaped manner. that is called Burns-Marshall technique, and modified Millivitz technique, and forceps delivery. These are the various means of delivery of the aftercoming head in breech presentation. In nested breech delivery, when the foot comes first, then you must catch hold of the buttocks, then pull the buttocks up to the trunk, and when the umbilical cord is in, keep the umbilical cord to one side and deliver the arms. Then you must go for Burns Marshall technique, where you have to bring the fetus towards the maternal abdomen. This is how catching hold of the hands and bringing the cord. This is called Burns Marshall technique. When we are delivering the head, you must guard or protect the perineum so that the head doesn't come out all of a sudden. If we allow the head to come out in Burns Marshall technique by bringing the head suddenly, you are likely to cause in you are likely to cause this is what we have to do by Burns Marshall technique to bring the both legs towards the maternal abdomen, and the head will sweep over the perineum and delivered. While delivering the head, it should not come out all of a sudden because it will sudden jerk of in delivery of the head will cause intratentorial tear and intracranial hemorrhage, and which may cause neonatal death of the fetus. So you must be very careful in delivering the aftercoming head in breech presentation. Then, when the shoulders are extended and when they are in the nuchal position, that means both the hands are behind the occiput, like this, or when the hands are extended, then we have to apply what is called Smiley-Witz, Morse-Smiley-Witz maneuver. This is, you must keep the baby on your arm, and then this is also called jaw flexion and shoulder traction. Flex the jaw to keep the head flexed, then apply traction or the catching the shoulders. This is also called jaw flexion and shoulder traction method, or it is called Morrison-Smiley-Witz maneuver. This is how you will deliver the shoulders when they are in a nuchal position or an extended position. This is how you are going to deliver. This is the neck inside the vagina, and these are the two hands. We catch hold of the trunk with the hands and keep the hand aside and protect the cord from compression. What are the complications in breech delivery? In breech delivery, premature rupture of the membranes and imperfect dilatation of the cervix. When the premature of the membranes occurs, it mostly occurs in a complete breech presentation, where the buttocks doesn't fit into the pelvis properly, and the prolapse of the cord. In complete breech presentation, the chances of cord prolapse are more, and extended arms and nuchal position of the arms, difficulty in aftercoming head, and in extended breech. These are the complications of breech delivery. One is premature rupture of membranes and imperfect dilatation of the cervix, that means incomplete dilatation of the cervix, prolapse of the cord, and extended arms, as I said, where we adopt Smiley-Witz maneuver, and that is jaw flexion and shoulder traction method. and nuchal position of the arms, and difficulty in after coming head, and extended breech. Management of complete breech delivery. Delay in the descent of the breech. Arrest may out, occur in the outlet, cavity, or in the brim. Arrest at the outlet causes big baby with extended legs, weak uterine contractions, rigid perineum, outlet contraction. In any breech delivery, you must give liberal episiotomy. Management of the arrested outlet. If outlet is contracted, baby is big, and fetal condition is good, go for cesarean section. In the absence of outlet contraction and feto-pelvic disproportion, liberal episiotomy. If it fails, single groin traction or traction on both groins. If the baby is live, if the baby is dead, we can apply traction with breech hook. If it fails that the baby is still living, anterior leg is to be brought down. If baby is dead, the groin traction fails, baby may be delivered by breech hook. Arrest of the breech at or above the level of the ischial spine. The most probably due to contracted pelvis, weak uterine contractions in the big baby, multigravida with pendulous abdomen. Then, to manage it, if the contracted pelvis or feto-pelvic disproportion, go for cesarean. And otherwise, you can try Pinot's maneuver to get the breech above the left level of the ischial spine. You can catch hold of the feet of the baby and flex at the knee. Bring one leg. Later, you can bring the other leg by the same maneuver. That's called Pinot's maneuver. We call it as when there is a disproportion between the breech and the pelvis, you call it as feto-pelvic disproportion. If there is a presenting by cephalic presentation, we call it as cephalopelvic disproportion. So this is very important. When the fetus is presenting by vertex, you call it as cephalopelvic disproportion. When the fetus is presenting by breech, you call it as feto-pelvic disproportion. In extended arms, the classical method and the Lauser's method, as I said, in extended arms, we have to manage with classical method or Lauser's maneuver. This Lauser's maneuver, as I said, you have to catch hold, you have to extend your arm, turn the baby to one side, and then you extend your hand, you flex the jaw, and in Lauser's maneuver, we turn the fetus to one side, rotate the fetus, and by 180 degrees, bring one shoulder, and again rotate the fetus by in the opposite direction to 180 degrees, then deliver the other shoulder. This method is called Lauser's maneuver. This we adopt where the extended hands or nuchal position of the hands. Arrest of the aftercoming head at brim. This is due to deflexed head or contracted pelvis or hydrocephalus. Due to the deflexed head, delivery is completed by molar flexion and shoulder traction. And if arrest is due to hydrocephalus or contracted pelvis, perforation of the head is done. Usual site of perforation is in the occipital bone. The where to perforate, if the fetus is dead, where to perforate and at the occipital bone, not in the any anterior frontally or posterior frontal. If you perforate in the soft part of the head, it will collapse and it closes the perforated hole and it prevents the drainage of the brain matter. So you must always attempt perforation at the occipital bone so that the perforated part doesn't get collapsed. And in hydrocephalus, when it is due to the difficulty in the aftercoming head due to hydrocephalus, we got two means to decompress the head. One is you ask the patient to pass the urine or catheterize the patient to empty the bladder. Then you put in a needle in the head of the fetus, perabdomen, then aspirate with the syringe so that the head, the fluid will be drained. Cerebrospinal fluid will be drained into the syringe. Then the head gets collapsed. Then you can bring the head down. Otherwise, you can, as the head is only left inside the pelvis, rest of the part is outside the vulva. You can put in a needle into the spine and aspirate the fluid to take out the cerebrospinal fluid so that the head gets collapsed and you can deliver the head. Arrest of aftercoming head at outlet due to rigid perineum and deflexed head. Baby is living, cervix is pushed up while traction of the trunk is made by molar flexion, shoulder traction. If the baby is dead, perforation of the head is done. Arrest of the aftercoming head in the cavity. The head may get arrested at the brim, at the outlet, cavity, and at the brim. The causes of arrest of aftercoming head in the cavity, the cause of deflexed head and contracted pelvis. Management, delivery of the by forceps. The forceps, what we use for the delivery of the aftercoming head, is ideally we have to use Piper's forceps. But nowadays, Piper's forceps is not available. We can apply an outlet forceps by pulling the baby up, catching hold both the legs by the assistant. You can apply forceps to the fetal head and pull. This is called forceps application for the aftercoming head of the fetus. What is the role of external cephalic version? External cephalic version, the success rate of version is 70 to 80%. The ideal time is 36 to 37 weeks. Prior sonography has to be done as a routine to assess that all the fetus is in good condition, and CTG should be ideally done before and after procedure. The external cephalic version, where we'll try to bring down the head by clockwise rotation, catch hold of the head and turn it slowly towards the pelvis so that the breech reaches the fundus and the head comes onto the pelvis. So the success rate of external version is only 70 to 80%, and the ideal time of doing external cephalic version is around 36 to 37 weeks. Prior sonography as a routine, CTG should be done before and after the procedure. Is what? You catch hold of the head, turn it in a clockwise direction. We'll bring the podalic pole to the fundus and the cephalic pole into the pelvis. So this is how we do external cephalic version. What are the contraindications for external cephalic version? This is severe preeclampsia where the BP is raised and all the signs of preeclampsia are present. We should not attempt external cephalic version. In post-cesarean pregnancy, where already a scar is there on the uterus, we should not attempt external cephalic version. And history of bleeding in early months suspected placenta previa, where it may bleed again, and even if we bring the head down, the placenta previa may obstruct and it may prevent the head to enter the pelvis. And again, in the severe degree of contracted pelvis, we should not attempt external cephalic version. In fetal causes, the malformations, hyperextension of the head, and dead fetus, we should not attempt external cephalic version. Malformations of the uterus, like arcuate uterus, uterine diadelphus, all these malformations of the uterus, you should not attempt external cephalic version. In multiple pregnancy is also contraindication for external cephalic version. The cause of failure of version. Even you attempt external cephalic version around 36 weeks of gestation, it may fail and the version may not take place because of the breech with extended legs. We can't turn the head down and scanty life here. When the adequate life is there, we can attempt this procedure of external cephalic version. And obesity, increased tone of the abdominal muscles will prevent rotation of the head. In congenital abnormal malformations of the uterus, we can't attempt this external cephalic version. And even if we attempt, it will be a failure. And undiagnosed twins and short cord. When the cord is long, we can attempt an external cephalic version. When there is a short cord, when we attempt version, there may be premature separation of the placenta because of the traction on the cord. These are the causes of failure of version when we attempt external cephalic version. Indications for cesarean delivery: large fetus with estimated fetal weight of more than 3.5 kgs, IUGR, intrauterine growth retardation, preterm fetus, any degree of pelvic contraction, hyperextended head, and foot presentation are the indications for cesarean section. When there is a large fetus, intrauterine growth retarded fetus, premature or preterm patient, any degree of pelvic contraction, hyperextended head, foot limb presentation are the indications for cesarean delivery. Failure to progress due to inertia, failure of descent, and prolapse of the cord when the fetus is in good condition and the cervix is partially dilated. These are the indications for cesarean delivery. Questions and answers. Any questions from your side? Why? Any questions regarding breech presentation? This is one of the topics, important topics in optics, which you are likely to get in the exam or in the clinicals also. No questions? Actually, questions లేవా? వస్తారా? The Gaskin maneuver, it doesn't come in the breech presentation.
అయిపోయిందా ఇప్పుడు మాట్లాడారు సార్ ఎనీ క్వశ్చన్స్ ఏదో ఒకటి అడగాలి చార్ట్ అడగాల సపోజ్ కంప్లీట్ గా ఇంకా అయిపోయింది ఏదో నొక్కాలి ఇంకా ఈయన లేచిపోవడం అన్ని రికార్డ్ అవ్వకూడదు ఇది కింద ఎగ్జిట్ ఉందా ఇప్పుడు నొక్కున్నాను అది నొక్కి మరి ఇంకోటి పెట్టేస్తాను ఇదంతా రికార్డింగ్